Dr. Neha DHOLAKIA, who's come from Mumbai, DHOLAKIA Eye Center. And she has a very interesting innovation which I've used personally, and I find it to be a really path-breaking innovation. So welcome, Dr. Neha. Can we
Thank,
have the slides?
thank you. So, beginning से करेंगे please. Can you all see it? Yeah, start कर सकते हैं. So basically, broken IOL complications have been the most dreaded complications for years. You do a perfectly good cataract surgery and you see the haptic optic junction break, or you see the lens just shoot through and puncture the PC. And I think we all have experienced this at some point in time, and we're really disappointed. We have to remove the IOL. Sometimes we insert the IOL, and these are good lenses. These are not second-grade lenses. These are the best companies in the world. So this is an Envista. The previous one was an IQ. And then we have to remove the IOLs. The current methods are either extend the full incision or the twist and out technique. Thoda volume बढ़ाएंगे.
Volume.
And this twist and out technique, if you have a rent, you can't do. You have to be a very expert surgeon to be able to do it. The third is using the scissors. And here, because of the opening and closing of the jaws of the scissors, you can touch the endothelium. And if it's open behind, it can even puncture the PC. This can leave behind striate keratitis and sometimes even Descemet's detachment. Corneal edema is generally very common. So here is, thoda music बढ़ाएंगे please. So here is innovation where you see the lens is being held by a special forceps, and the tip, which is just like a phaco tip, it's a solid tip, not hollow, but it has a sharp V-shaped front, and you just slice through the lens as if cutting through butter. You can slice the lens into 1, 2, into 3 parts, but if it's a little bigger, thicker lens, maybe even 4, 5 slivers. And then you just realign the pieces and remove them. So first you have to prime the phaco probe, just as you normally do. Once the phaco probe is primed, this is what the tip looks like. It's made of titanium. The forceps are made of steel. And all you do is just press on the foot pedal, and you can slice the IOL into 3, 4, 5 slivers. Always, I would suggest that to try it first under vitro, in vitro under saline. The temperatures were checked at the tip. Normal phaco tip versus the IOL cutting tip, both were more or less the same. The vacuum has to be 0, aspiration 0, irrigation should be on, and longitudinal power, not torsional, not linear, just fixed longitudinal. I have cut even IOLs at 20% power, so between 20 and 30. It's very important to give good counter pressure. In industrial use, this is how it would be to cut a piece of plastic with a blade versus an ultrasonic cutting blade. So in the first case it was impossible, but here it is possible. There are separate tips based on the length, the thickness, and the threads for different machines, but we have tips for all the machines. Avoid interchanging a tip from one machine to another. It will work, but it will not give you the optimal power. So this is a case of a 60-year-old male patient. He used to drive at night. He was one-eyed. He had come from Dubai. And during the primary surgery, the injector got jammed, and because of that, there was pitting on the IOL. He wanted to be specs-free, and though his vision was 6/6, he had severe dysphotopsia. Explanting, you can see the pitting there. And this was operated by Dr. Santosh Bulchandani from Bombay. And he called me, he's saying, Neha, can you send me the cutter immediately? Luckily, I happened to have one for his machine. So under visco, he's sliced it. And this patient after the primary surgery, didn't have astigmatism at all. So through the same 2.2 millimeter superior incision, without extending it, without stretching it, without twisting, he could remove the IOL very easily. He implanted another IOL in the bag. And this was the result on day 1 post-op, plano 6.6. He had a crystal clear cornea. You can see the air bubble. It's just the first day post-op. Patient was very happy. He could fly back in 3-4 days. The second case done by Dr. Kamal Kapoor, opacified IOL, 32 diopter, hardened, high hypermetrop, very shallow AC. So here he's not tried to manipulate it too much because the AC depth is not great. So here he's first cut the haptic optic junction and then he's just cut it into 2. You can rotate the IOL and do stuff, but here since the space was very less, he didn't want too much manipulation. So he's just cut it into 2, but one can always cut it into 3 slivers also. And now he had to extend it just a little bit. So broken IOLs at the time of implantation is one indication, which is something we're always very fearful of at the end. Opacified IOLs to be removed, and these are little harder, so with the scissors they are difficult to cut, but with this they are really easy to cut. Dislocated subluxated IOLs, IOL exchange for halos and glare dysphotopsias. In the future we will get a lot of refractive surprises with patients who've been operated for LASIK prior, and if they have very high expectations, having this tool, God forbid something goes wrong, we can just like a vitrectomy cutter have this as a standby. And I think every second day I get a call from somewhere in India that we used your tip and it was truly very helpful, and thank you very much. It's the website is iolcutter.in. Once again, if you just notice, I have to give good counter pressure with the left hand. The sleeve is intact. One can ETO it and keep it aside. Now, when I did this, Dr. Pankaj Lande, he sent me a video. He's saying, ma'am, I've used it for another thing. He's giving good counter pressure, and this is a very hard black rock solid cataract. And here you see he's using the counter pressure with a hook and using the lower jaw, the lower V of the IOL cutter. And honestly, he's done it like almost like a femto, and he's very skillful a surgeon, and now he goes ahead and clears it up. So this is an off-label use. This tip has been patented now, Australia, UK, US, India, and this is just one more off-label use which I thought I should share. Thank you very much.
Thank you, Dr. Neha. So the two things that I wanted to bring about when I used it
Yes.
is one, the machine realizes there is something else,
Yes.
so it shows an error every now
Yes,
and then.
yes.
So you have to be ready to get out of that error to continue it.
Yes, yes.
And the second is rotating the IOL, because sometimes grasping the IOL after making the first sliver is very difficult.
Yes, because the center is very thick. So one can again bring the thinner part towards the side of the forceps and then grasp it again. So that little maneuvering, I think one case, if you do, then you are very confident about the second case.
Yes. Also, one last point was using a good viscoelastic, maybe
Yes.
like a soft shell again.
Yes.
Using a dispersive and then a cohesive, so
Absolutely.
there's heat dissipation.
Yes.
Because I'm sure some heat dissipation is there, but otherwise it cuts the IOL just like butter.
Yeah. It's good, and I feel very happy because I think there are far better surgeons than me, and what I could do in my cases, they've done such a brilliant job, including Samresh, and it's very heartening to just get these videos from everywhere. So thank you very much.
Thank you, Rokne.
Bye. Bye.